Okay, so talking about non-OCD anxiety, we'll talk about OCD later today. So as far as what's new regarding first, like treatment of anxiety with kids, CBT is still sort of the standard of care, and there is some research looking at like cognitive bias training and different aspects of the therapy for it, as far as what you're talking to kids about in terms of during cognitive behavioral therapy. If we look at medications in the last 2 years, there's really nothing new in terms of medications for anxiety disorders in kids. There was a recent article published by Jeff Strawn in 2018 that reviewed 2 unpublished studies of buspirone in kids that showed it was well tolerated, but it wasn't effective. John Walkup and Tim Willens and other people who participated in the study said that probably part of that was dosing, that the kids seemed to need 20 milligrams 3 times a day, but nonetheless, it was that those studies are unpublished and they were negative studies, but it's well tolerated. There was a comparative effectiveness study published last year in JAMA Pediatrics comparing CBT and pharmacotherapy, and basically it said that kids who were received medication that was better than receiving no treatment at all, and same thing with CBT, it was better than being on a wait list and not receiving treatment. So sort of just, and so that basically the active treatments were better than non-active treatments. There was an article published, I think it was last year in JCAP, that was a stepped care that looked at having kids, stepped care for anxiety. So people would come in and they would get like online training about cognitive behavioral therapy. They would get like a CD to use at home or online training and just a few telephone calls. And that was worked for 40% of people. Then people moved on to a manualized treatment before going on to individually programmed CBT. So they kind of looked at those kind of treatments. But that's kind of what's new out there that wasn't. The stepped care should have been on the last slide. So there are a few things in adults that have been looked at as far as medication. There was a randomized control trial of vilazodone in adults for separation anxiety, like adult onset separation anxiety, which is not a diagnosis I make very often, but nonetheless that was a positive study for vilazodone. There's been a number of studies with Duloxetine. There was a randomized control trial in adults with generalized anxiety disorder, and there was also a meta-analysis of Duloxetine for the use of generalized anxiety disorder, and both of those indicated that it was effective for treating GAD in adults. There was also, interestingly enough, a randomized control trial of Duloxetine in adults who have major depressive disorder and comorbid social anxiety, showing that that was helpful. So, we may see some studies with these 2 medications for pediatric populations in the future, but right now there aren't any studies with it that are published. There was one small study looking at Duloxetine and the pharmacokinetics in youth, ages 7 to 17, published in the Silver Journal. And that showed that basically their pharmacokinetics were similar to adults. So I'm assuming that we'll then see studies looking at the efficacy, but they aren't published yet. So really not a whole lot new in terms of medication for anxiety in kids. A little bit, most of the research is sort of around cognitive behavioral interventions or therapy interventions right now. So in terms of the guidelines, I'm trying to keep this short and keep us on timeline. For kids under age 6, I didn't recommend any changes. It basically says level 0, comprehensive assessment. Level 1, start with psychotherapy for at least 12 weeks. It includes the parents, because these are young kids, and some exposure-based training that's adapted for young kids. Level 2 is if you have a poor or partial response to psychosocial treatment after at least 12 weeks, consider combining that with fluoxetine and concurrent psychotherapy for kids ages 4 to 5, so in the older end of this age range. Nothing really new published for young kids with medication. So we based the fluoxetine recommendation in the past on the very small selective mutism literature. And then level 3 was if fluoxetine was not successful, you could consider using sertraline in combination with the concurrent psychotherapy. And always just
keeping it all.
Yep, keeping it all the same. Yep. Right, so no, I think these are the same, not recommended use of medications without psychosocial treatment, use of TCAs or alpha agonists, use of ongoing benzodiazepines except for short-term for procedures. I guess the only thing would be whether people want to, I don't think there's any literature about using alpha-2 agonists at this age group for anxiety. There's some in older kids, but there isn't really anything studied at this age. So whether or not we want alpha-2 agonists to stay, I think if you're treating a very young kid for anxiety, hopefully you use an SSRI if you're using medicine at all. So, all right, anybody else have any thoughts about?
No.
No. Okay. So if we look at kids ages 6 to 17, basically, again, level 0 is the comprehensive assessment. We've got the rating scales that are online that people can use. I didn't really see anything new as far as rating scales to be using or recommending. And so then level 1 is if there's a mild to moderate anxiety disorder, start with psychoeducation regarding anxiety disorders and starting with an exposure-based CBT. And then here we have it said that 1B, if CBT is not available, to first consider evidence-based psychosocial intervention. So if you don't have good high-quality CBT, try to at least use, there are articles published that talk about what are the essential components of CBT as far as, especially treating anxiety disorders, so having some exposure and those sort of things. So it's basically CBT or some sort of psychotherapy. And then level 2 said if there's a moderate to severe anxiety disorder or they've had a mild disorder but they have inadequate response to CBT, to initiate treatment with fluoxetine or sertraline, either alone or in combination with the CBT. So 2A is, start with fluoxetine or sertraline. If you want to have monotherapy instead of the word alone, that's fine. Monotherapy, yeah.
Alone means medication without CBT,
which is fine.
Monotherapy.
It's not what we recommend. It's not best, but it is done in studies, right? If you have the CAMS, there was an arm that just had sertraline. So, we're saying level 1 is use psychotherapy. And so level 2, you would be documenting that you don't have therapists available, you don't have CBT, or you don't have therapists available, or for some reason the family can't get to that. So it is acceptable to use an SSRI monotherapy if it's a severe, moderate or severe case. It's not ideal, it's not what you want, but you could do it.
Consider online or app or electronic app methods.
So the second point here is, so level 1 says use CBT, and 1B says if CBT is not available, then you use an evidence-based psychosocial intervention.
But it doesn't specify online and...
Yeah, if you want to add that, because there are more studies about that these days.
We do have evidence for it.
Yeah, because the stepped care is an online.
What do you think about adding that?
I think that would be fine to add as options.
How would you word it?
Either web-based or...
Well, you could put EG, I would put it in parentheses, like EG, other psychotherapy, online.
If you put it in EG, then people are going to give us an afterthought. If you cannot access therapists with this skill set, there are these methodologies that do have evidence.
And there's evidence for other kinds of psychotherapy as well. So I'm saying you would just add it here as in a parentheses, EG, and give some examples of online.
Resource issues in Florida, I'd rather just direct them straight to the electronic.
Like what?
Well, as I mentioned,
What is it that you can access that your patients are able to access online?
Well, I think again there are various web-based approaches. There are apps.
But the apps aren't necessarily evidence-based. Now, there are some, so that, like Cool Kids is online. If you live in Australia, you can do that for free. But I talked to them, to Rappy, or however you say his last name, and we can't access it from the US because I was thinking, well, we could have our kids access that. But there's like for the depression literature, there's Sparks has all these articles published, but you can't access it. There is Brave Online, which I think you can access Brave Online. But when I looked, there was a lot of them that are published about that I can't actually see how to get my patients registered for them. So I think that that is an option. And these apps, you don't necessarily know. Like even for meditation, is Headspace the same as meditating with a teacher? I guess I'd have to I have looked at online, there are articles published about online treatments for anxiety. So level 2 was fluoxetine or sertraline monotherapy or in combination with CBT. If the first 2B is if the first SSRI trial with fluoxetine or sertraline is not effective and there are treatment limiting side effects, switch to the other SSRI that's not been used. Right. And this says initiate or continue CBT. So if you're having to switch medications and you haven't started CBT, you should switch plus starting CBT. So no. So then level 3 was if therapy and 2 SSRIs are not effective, then you can use Duloxetine, either alone or in combination with CBT, monitoring height, weight, blood pressure, pulse.
So duloxetine is the only?
Yep, duloxetine is still the only FDA-approved medication for treating anxiety disorders in this age group.
Yes.
However, Jeff Strawn, who led that study, also says that he still thinks it's better to use a serotonergic medication for anxiety disorder. So we have duloxetine at level 3, or 3B could be fluvoxamine, which it has good. Fluvoxamine has good data for OCD, but not as much for non-OCD treatment related. I'm not even sure if we need to have that in here, but since it's non-OCD related, but we had it before, so I was just leaving it. There's nothing new to say that we shouldn't have it if we had it before. And then level 4 was if levels 1, 2, and 3 are not successful, consider reassessment or refer to a specialist. And level 4 also has, if level 3 medicines are not successful, you can consider citalopram, or venlafaxine in combination with the CBT. Yeah, and so then the last part is just the not recommended, paroxetine as first or second line, and benzodiazepines as first-line monotherapy for long-term treatment of childhood anxiety disorders.
Thank you, Dr. Stock. We really do appreciate that wonderful presentation.